Welcome back. So, did you think we can't do anything anymore if that scenario happens with immovable foreign bodies? Of course not. That is what esophagotomy is for. Let's begin. Esophagotomy is the surgical opening of the esophagus. The surgical approach would depend on the specific region of the esophagus where the foreign body is lodged. If it is in the cervical esophagus, a ventral midline cervical incision on the ventral neck is done, as you can see in this image. If it is in the thoracic esophagus, at the point of the heart base, the approach would be a right lateral thoracotomy. If the foreign body is cranial or caudal to the heart, a left lateral thoracotomy is indicated. A ventral midline ciliotomy is indicated for distal esophageal foreign bodies, but this is commonly shifted to a gastrotomy approach. For cervical esophagotomy, a stomach tube is pre-placed to help identify the esophagus. Remember, the trachea is more ventrally placed, and you would need the gastric tube to make the esophagus more superficially positioned. The surgical site is prepped and draped aseptically. Skin incision is made on the ventral cervical midline from the larynx, extending caudally to the manubrium. You still remember what the manubrium is, right? Manubrium? That is the first segment of the sternum, correct. You must now separate the paired sternohyoid and sternocephalicus muscles to expose the trachea. Carefully retract the trachea to expose the adjacent anatomic structures. What are the important structures near the trachea? We have the thyroid gland, the cranial and caudal thyroid vessels, which supply the thyroid, the recurrent laryngeal nerve, and the carotid sheath. This one. What are the contents of the carotid sheath? Again, review on anatomy. What is inside the carotid sheath? This would be there are three structures within that. You have the carotid artery. Good guess, that was easy. What else? There's a vein in there too. What is it? That's the internal jugular vein. And there's also a nerve. Because remember, they always travel together. Artery, vein, nerve. The nerve would be the vagosympathetic trunk. Correct. And for those who were not able to remember that, that's okay. But that tells you need to review on your anatomy. Okay? Once you have visualized the esophagus, pack it off or separate it from the adjacent structures with saline moistened lap sponges. The same one that we used to line the edges of the abdominal walls when we did the exploratory laparotomy, remember? Same thing. The ingesta within the esophagus must be stopped from accumulating in the area we are going to incise. You may occlude the lumen cranial and caudal to the planned incision site with the fingers of your assistant. Stay sutures are placed, cranial and caudal to the planned incision site. The stay sutures help to stabilize, aid manipulation, and avoid trauma to esophageal edges. Make a stab incision into the esophageal lumen and extend this longitudinally as necessary to remove the foreign body. If the esophageal wall appears normal, you may incise over the foreign body. If not, incise caudal to the lesion. Carefully remove the foreign body from the esophageal mucosa. Always assess the mucosa and the adjacent structures to fully see all damage. Perforations may not be seen easily, so closely examine the lumen and the esophageal walls. Once you are sure that there are no more damage that needs to be fixed, irrigate the area and prepare for closure. In closing an esophagotomy incision, a two-layer closure is indicated. A two-layer closure provides better and faster wound strength, better tissue apposition, and improved healing. The first layer of your suture must incorporate the tunica mucosa and submucosa. Remember that the submucosa is the holding layer, meaning this layer holds the whole wall together. An inverting suture is preferred with intraluminal knots, meaning the knots are placed within the esophageal lumen. You need to invert the knots to prevent leakage and minimize foreign body reaction within the esophageal walls. The submucosa, muscularis, and adventitia are closed as the second layer and ideally is opposed using simple interrupted sutures with extraluminal knots. If one-layer closure is preferred, especially for those with thin esophageal walls, suture through all four layers with extraluminal knots. After all that, do not forget to check for leakage. This is done by occluding the lumen, both caudal and cranial aspects of the incision, injecting saline on the surgical incision site, applying gentle pressure, and observe for leakage of the injected saline in between the sutures. The skin is then closed routinely. To summarize the principles of esophageal surgery, number 1, use the most advantageous approach. You have to identify what technique would be highly beneficial to your patient with the most atraumatic technique possible. With that, use this technique to compensate for the poor healing of the esophagus. Dissect sparingly and preserve vasculature since the esophagus has a segmental blood supply. Make incisions through healthy tissue to prevent further damage to the esophageal walls. Make longitudinal esophagotomy incisions, meaning if this is the esophagus, incise this way, not that way, because that will make closure very, very difficult to achieve. Inspect for contralateral perforations and necrosis, meaning check the ventral and dorsal aspects of the esophagus. Incorporate the submucosal layer with all the sutures. And observe the location of the knots if you are doing one-layer closure or two-layer closure. After an esophagotomy, you must observe for 2 to 3 days for signs of esophageal leakage and infection, since these are the most common complications post-operatively. Antibiotic therapy is indicated for at least 2 weeks, maybe longer for those with aspiration pneumonia because of esophageal perforations. After a foreign body removal, all oral intake is recommended to be withheld for a minimum of 24 hours to minimize esophageal trauma. Water is first given after the 24-hour fast, followed by small amounts of a blended diet. This is gradually shifted to soft, moist food for the next 7 days. For minor foreign body removals that were resolved with endoscopy, you can start feeding at an earlier time, given that no vomiting is seen. Ultimately, it is upon your assessment of your patient when you want to reintroduce it to food and water. Administration of H2 receptor antagonists and proton pump inhibitors aim to reduce gastric acidity to control vomiting and to prevent more damage to the esophageal mucosa lining. Examples of H2 receptor antagonists would be cimetidine, ranitidine, famotidine, and examples of proton pump inhibitors would be your omeprazole, pantoprazole. Analgesics, as a routine, is always indicated for post-operative pain management. So what can we do with this case? The story behind this is that this puppy was found from the street and was vomiting. So it was rescued. They immediately thought it was parvo in the first clinic and was transferred to another clinic. There, the veterinarian, luckily, did a quick physical exam and thought, hey, what's that there at the back of its throat? So they x-rayed the little guy and found that it has swallowed a whole fishing pole. What can we do? Well, luckily, the metal rod was carefully pulled out of its mouth. After the puppy was sedated, they used a long pair of Kelly forceps, and they were able to gently, gradually, dahan-dahan, hugutin yung rod from the entire esophagus. So that's pretty cool, right? So far we have discussed the different treatment options for foreign bodies. But there is another important surgical procedure which involves the esophagus. And you just have to add one letter to the title of this lecture video. Want to find out? Click on the next video. See you there, guys.